involves variation of size of afferent to efferent, true. The juxtaglomerulus apparatus, which includes the macula densa and the cells of the distal tubule, recognize low sodium, thus low pressure, blood pressure. If you have low sodium, you're not going to have enough water retained, so you're going to have low blood pressure. Okay, so that was true. Renal threshold, hopefully everybody got this right. It's false, 160 to 180. Bicarbonate is excreted with hydrogens in the urine and secretion. No, it is reabsorbed to help the bloodstream. Blood pH be 7.35, 7.45. ADH controls the amount of sodium reabsorbed. It controls the amount of water reabsorbed. Okay? False positive protein may be produced by the runover effect. Early detection of renal disease indicates these were 3 from your study questions on that page you had to know from graph. Early detection of renal disease indicates testing for microalbumin. The principle of protein error of indicators is based on protein giving up hydrogen to the indicator. B, the shield of negativity is the part of the endothelium of capillaries that helps to repel. Remember, that's one of the reasons you don't have albumin spilling over, because it's a small enough molecular weight that it could spill out, but the shield of negativity keeps it from spilling out. Which of the following is not a mechanism to maintain blood pH? Excretion of acetic acid. Confirmatory test that can distinguish both is the Watson-Schwarz.
Can you go back a page?
Hemoglobin will most likely be seen in the following urines. Hemolytic anemia, not fresh red blood cells. Yes.
Can you go back to 11 through
Yeah,
17?
yes, okay.
Oh, I'm sorry, I didn't turn it over. Sorry. Which of the urinary structures is involved in the countercurrent? The vasa recta. Water is reabsorbed everywhere but in the ascending. Renin, aldosterone are secreted in response to the low systemic blood pressure, low sodium. 14, sodium reabsorption is monitored by aldosterone. Water is monitored by ADH. A patient has a specific gravity of 10 when it leaves the glomerulus. The 2 pressures that involve with glomerular filtration, onconic and hydrostatic. And the key normal pigment is urochrome.
Gee, number 6, I think the book said that the false was all on the protein could be an alkaline pH.
Yeah, and I'll circle that and I'll check. Because if there's a choice of another correct, I'll give that to everybody, okay? So I will, because I know there were others than what we put on that sheet, so I'll circle it so that I'll check it. And then I can make it a choice of either one on your test. 18 then, we did the Watson-Schwarz. 19, 20, a common interfering substance causing false negatives. And I've seen this written in the registry books like this, where a very common one is ascorbic acid. So sometimes you'll see that they won't pinpoint a key one, but they'll come up with one they see as a common theme. Urobilinogen is increased and bilirubin absent. That is hemolytic disease, where there's no bilirubin. And then the bilirubin is positive only, and urobilinogen is normal, as seen in the obstruction. Plus, we know bilirubin decreases on light, so that should have been D. Diabetic monotherapy is glucose and ketones. And this one, I hope everybody got right. How can you detect galactose? It would be a negative dipstick, because that only does glucose. And then the Clinitest would be positive. And a lot of labs have any child under 2, they're going to do a Clinitest. That used to be our protocol at St. E's. Every child under 2 had a Clinitest, because it might be another sugar. Clear red would indicate the myoglobin and hemoglobin. What would intact red cells be? What would be the clarity on if you had fresh red blood cells?
Cloudy.
It's cloudy red. Key protein detected on the dipstick, the primary one is albumin. Okay, the confirmatory test, glucose, bilirubin, oh, I got that wrong. It's ketones, I gotta make sure I change that on my answer key. Ketones, glucose, bilirubin, protein. Ketone bodies, that is true. Incomplete fat metabolism, 28. On 29, the thing that should have popped out was the moderate bilirubin only, so then that goes with bile duct obstruction. Vince-Jones protein, multiple myeloma. Urine that can be trace and normal, orthostatic proteinuria. The urine that darkens upon standing was that melaninuria and alkaptonuria. When we get to our amino acid disorders, we're gonna have that one again. That was with color. Positive ketone would go with the glucose that you'd be looking for. 34, a false negative bilirubin, the exposure to light. Test that confirms porphyrin only was the HESH. And testing for microalbuminuria is the diabetic nephropathy. Confirmatory test where the analyte remains on the top of the pad would be the bilirubin remains on the top in the ICTO test after you drop the 5 drops of urine. The protein precipitates at 40 to 60 degrees. It goes away at 100. Refractometer measures velocity of light in air compared to light in a solution. That is true. Specimen had a low specific gravity in polyuria. You would go with diabetes insipidus. If their output was only 200 mils per 24 hours, you would go to oliguria. If they hadn't voided in 2 days, that's anuria. One of the automated analyzers is the iris. I think a lot of you will see that. A common odor with glucose in the urine would be a sweet odor. And the one that isn't an intermediate product of fat is the ketoacetic acid. The others are common, and you got a second bonus, multiple myeloma. So hopefully you got both of those right. Leukocyte esterase goes with ascorbic acid. Ketones goes with specimen sat too long. They'll evaporate and then there'll be a false negative. Bilirubin, the exposure to light. Nitrite, if it's a gram-positive bacteria, it'll be negative on the dipstick. And pH was the acid run over from the protein pad.
What was 51 again? B.
E. Glucose, detergent in the container, a false positive. Ketones was the levodopa. Urobilinogen was porphobilinogen. Blood was menstruation. And protein was urine sat too long. And then ketones went with nitroprusside. Bilirubin with diazo. Nitrite with grease. Urobilinogen, arylic, and pH bromothymol blue. And here you could always write methyl red, could have been a choice as well. Blood went with peroxidase, leukocytes, the esterases in neutrophils, and which is kind of a key thing. It's not in the other white cells. Protein, the tetrabromophenols blue is the indicator. Glucose, I gave you both. Oxidase is the key one, but that's part of the reaction as well. And specific gravity was that pKa of polyelectrolytes. So the one that is reabsorbed in the bloodstream to maintain the blood pH is bicarbonate. The other two for excretion, phosphate ion, ammonium ion.
Did you have to put the ion?
I'll look what everybody puts, just to see if you say phosphate or ammonium. Okay? Specific gravity, it was 120. You had 1,000 or milligrams or 1 gram. You had to subtract the 0.004, so that should be what you report. Specific gravity was off the scale. you should dilute it, whatever your dilution is, you run it. If it's like, you diluted it times 2, and you ran the dilution on the refractometer or the dipstick, it would read 20, then you would report 20 times 2, you report 1040. And X-ray dye is very, probably the most common thing. When they have some kind of dye injected before they get a CAT scan or an MRI, you might get that 1.060 specific gravity. And you're going to have to dilute it because your strips and your refractometers don't read that high. Have you talked about linearity in chemistry? Linearity is key. You can't just take the result off if it's too above the linearity or below. Same way with a refractometer. If there's linearity for an analyte, you got to dilute it then if the machine doesn't dilute it. If they had a lot of whites and many bacteria, you're going to worry about an infection in the urinary area. And the nitrite could be negative if it was a gram-positive organism and not a gram-negative. If they had a negative bilirubin and a high urobilinogen, the hemolytic anemia, and the 2 confirming tests, and you could have got this all from the Scantron. Okay, so hemolytic anemia, Watson-Schwarz, Hesch. If you have high protein over 100, you're going to be thinking some kind of kidney problems. All you need to put was kidney disease. And then under the microscope, you're going to confirm blood, look for red cells. On leukocyte esterase, look for white cells. And if you have a nitrite positive, you're going to look for bacteria.
What if you just put blood, glucoside, and nitrate?
As long as it covers those 3.
Okay.
I mean, as long as you have blood, leukocytes, and nitrite, those are the key ones we look at under the microscope. And then on the ChemStrip analyzer, I needed to see cleaning, calibrating, running the QC levels 1 and 3, and making sure the QC was in range.
So all I put was run QC, I didn't put 1 and 3. Is that
Yep, you
going
gotta
to-
have them all to get the total points. I'll give partial points, but it is key. You gotta clean it, you gotta calibrate it, you gotta run the QC and make sure your QC is in range.
I did that, but what I said is I run controls and then check within range. I didn't say run controls 1 and 3.
Well,
that
we'll
going to be
see
wrong?
what everybody put, okay? Because it's not just one control, so it should at least be plural, that you at least need to run 2. So every test has to have two run minimum. And what I was looking for on the dipsticks, you remove them one at a time, you don't lay out dip strips in a row, and then you don't put them on the counter. When you get them out, if you're gonna lay it down at all, put it on like a clean paper towel. But bottom line, you want to use it immediately and close the lid whenever it's not in use. Because we found out we can't put them in old containers. All leukocyte esterases turn purple. So the strips need to be handled properly. And that was the beginning of the chemical dipstick PowerPoint.
I remember you saying don't touch the pad either. Is that okay?
That'd be okay too. You don't want to put your hands all over pads and you've had whatever, your hands wet or lotions. I want to just, before we go over, we're going to do lab first.
You forgot to go over the grid with the
Oh.
passive.
Sorry. Get with the, and, so pyridium was the common one for the orange color. And then that was your grid. Urea, water, water, urea, sodium, water, water for passive. And then active, glucose, amino acids, salts with sodium chloride, then sodium. And then on the blood, actually, I could have combined, so actually it only should have been 4 points because I asked why. This is a big deal. If you get a positive blood and you're not seeing anything under the microscope, that can be valid. It's because they might not be fresh red cells, they're going to be hemoglobin or myoglobin. And then you confirm if it's hemoglobin or myoglobin with the ammonium sulfate. Okay? So, think every time you're doing the test today. She gave me some pretty good ones. We'll see. That's why I didn't want to wait too long.
What was the orange color?
Pyridium, the antibiotic.
Okay.
If they put you on an antibiotic for a UTI,
Okay, good.
that's the classic one for
That's what I
orange.
So I think UTI medications is that going to count? or-
I'll see, I look at what everybody puts, but, so every time we're in lab, you know, we're not memorizing for the sake of memorizing.